turned white, if it's at all possible. He turned absolutely white. He said, prep her for the OR now. We're looking and saying, why? You know? I mean, could we give her something stronger than Haldol, please? You know, that's what we were thinking. This woman had a small bowel obstruction. This guy, obviously because of the so many years of training that he had, okay, he spotted it immediately. He didn't even have to lay a finger on her, and he spotted it immediately. She had a small bowel obstruction. The pain is excruciating. It comes in spasms and waves like that. We took her to the OR. She had surgery. Unfortunately, she died. Yeah, she died. But, I mean, I will never forget that now. See, I will always remember the incredible pain. And it's a wave of pain. Okay? Oh, there was one other thing I forgot to tell you. During one of my assessments of her, I was looking at her stomach and I saw something moving in her stomach, just like a wave. And I thought, what the heck is that? She got bugs and parasites in there. It was moving. I had no idea what it was. You know, and I told my friend, the first year intern, and he went, I don't know. Neither one of us knew. The attending knew it was reverse peristalsis. And that was almost a definitive sign for him that this was a small bowel obstruction. You will see reverse peristalsis, this wave-like thing happening. So I will never forget that. Reverse peristalsis. Severe constipation, vomiting fecal contents, and abdominal distension. In fact, it impressed me so very much that about a year and a half ago, a woman was brought into the ER, and she had severe abdominal pain. She was screaming just like this woman was. I saw the reverse peristalsis. And once I saw that reverse peristalsis, I said, open your mouth. Okay? When she opened her mouth, there was black in her mouth. And you didn't want to smell her breath because it smelled like fecal contents. And that black that was in her mouth, that was stool. When I put an NG tube down her, I got 500 cc's worth of black liquid stool. It was in her stomach. Because there's an obstruction. Can't go anywhere. Right? Cannot go anywhere. Can't go down. Got to back up. So, abdominal distension, reverse peristalsis, she will vomit fecal contents. Okay? You'll absolutely see the stool in her breath. She will have severe halitosis, severe bad breath. And if you get the chance to auscultate her abdomen, you'll find that she will have bowel sounds that are very high-pitched above the obstruction, and below the obstruction, it'll be absent or very, very diminished. Your nursing interventions, I told you what I did was what? Put in an NG tube right away. Okay, for me, all I wanted to do is decompress the stomach, so I just put in a Salem sump. But generally what we do is we put in a longer tube that goes into the intestines, so a Miller-Abbott or a Cantor tube. When you're putting in an NG tube, do you remember how to measure? And this is an NCLEX question, from the nose to the sternum. Okay, you need to remember this. Don't do this way. Yeah, there's an NCLEX question that one of the choices in the answer is earlobe, nose to sternum, and you have no idea how many people pick that. You know why? Oh, we got all the three components there. We got all three parts there. It has to be nose to ear to sternum, not ear to nose to sternum. Okay? So read it carefully, because the ear to nose to sternum comes before, in your answer choices, it comes before the correct one, which is nose to ear. So don't jump and pick the wrong one, just because it's got all three components. Okay, so slow down, all right? When you're inserting a Miller-Abbott or a Cantor tube, that's the one that has that little weight at the end, or the mercury weight or something. Okay, when you insert a regular NG tube like a Salem sump, you insert it, you've checked placement, and then you tape, right? You tape it to the nose so that it doesn't move anywhere. When you're inserting a longer tube, like an intestinal tube, you do the same thing. You measure nose to ear to mid-sternum, yes? You insert it to the point, but you do not secure it. You do not secure it, because what happens is that weight that's at the bottom of it will advance the tube until it's in place in the intestine. Once the position has been confirmed by X-ray, then you can secure the tube. All right? So Salem sump, regular NG tube, no problem. Insert, you put it in, you check placement with either the bolus of air or whatever. You tape it in place immediately. With a longer tube like a Miller Abbott or a Cantor tube where you actually have to end up going into the intestine, you measure, you insert it to the abdomen, and then you do not secure it. You let it advance. Placement in the intestine will be confirmed by an X-ray, and then you can secure it. All right? When you are taking it out, when you take out a Salem sump, what do? Tell them, take a deep breath, and you pull, right? One nice swift move. With the intestinal tube, you cannot do that. You have to pull back about 2 inches every 10 minutes. Just pull back a little bit, a little bit, a little bit, until it's in place in the abdomen. And then you can yank it out in one fell swoop. Anytime you have an NG tube in for an intestinal obstruction, you're going to be measuring abdominal girth. You're going to be watching for any complications. And remember, surgery very well may be in the cards. Okay. When you put in an NG tube, what do you put it in for? You can put it in for decompression, or you can put it in for feeding. Right. Let's cover very quickly. I won't go in great depth on hepatitis because I actually cover this in better and greater depth with obstetrics on tomorrow. Okay, so we'll cover it very, very quickly. I just want you to know that a long, long time ago we used to have hepatitis A, hepatitis B, and non-A, non-B, right? 3 types. Well, guess what we have now? We've got A, B, C, D, E, F, G. Yeah. And you didn't know about the others, right? But fortunately, what NCLEX wants to question you on is essentially A and B, C and D. Okay? You need to know your anatomy and physiology. You need to know what the liver produces and the job of the liver. Yes. So if you don't know the job of the liver, then go back home, pick up your anatomy book and your physiology book and study. We're going to cover very quickly hepatitis A, B, and C, cirrhosis, ascites, and esophageal varices. Okay? We're also going to cover very quickly cholelithiasis and pancreatitis. You know that with the liver biopsy, that is the definitive test for what? To rule out cancer. Anytime a patient is having a liver biopsy, remember the liver is a very vascular organ. What does that mean? It means it's got lots of blood vessels. That means it bleeds very easily. The liver also produces albumin. It also produces platelets, correct? It is the area where all the junk that you put in your body gets detoxified. So your medications, all the medications that you take into your body goes through what we call a first pass effect. It goes through the liver, and the first pass is the detoxification pass that goes through the liver. So your liver works very, very hard. So let's be respectful of it. Okay. All right. Your patient's going to have a liver biopsy. Preoperatively, you've got to make sure that a consent's been signed. Preoperatively, you're going to do basic lab work. You remember I told you the liver produces coagulation factors. So you're going to draw blood work, PT, PTT, coag factors, right? You're going to do that clotting screen beforehand. You're also going to do what? You're also going to do liver functions because you want to make sure the liver is working all right. Tell him that he does not have to go to the OR for this. It can be done in his room. And essentially what he's going to be doing is he's going to be laying. Now, different doctors have different ways of doing this. Okay, most doctors will tell him you want some supine, which means on his back, and his right quadrant will be exposed. What's going to happen is that you tell the patient he has to hold his breath when the doctor goes in with the needle. So he doesn't want him breathing because when you breathe, the liver is right up against the diaphragm, so every time he breathes, okay, that liver moves as well. So tell him to hold his breath. All right, post-operatively, he is going to be laying on his right side. And you tell him this before he goes in. before the biopsy is done. He will be laying on his right side. Why? Because we want to put the pressure. All right? And he's going to be doing that for, about 6 to 8 hours. Yeah, nice healthy period of time. You want to watch very carefully for any possible oopsies. I love these oopsies. Okay, and the oopsies include puncture of the bile duct. Maybe we gave him a pneumothorax. Remember, the diaphragm's right there. So maybe we give him a pneumothorax. Okay? Peritonitis. We want to watch for all those wonderful things. Now, we've got, like I said, hepatitis A, B, and C. With all the forms of hepatitis, you need to know that you want to rest the liver. You need to know that you want to give him a high-protein diet. Why? Because the liver makes albumin, and albumin is protein. So you want to give him a high-protein diet. Okay? Rest the liver. If he drinks, he needs to stop. If he does not stop, it can lead to a condition known as cirrhosis. And we all know what cirrhosis is. It's a direct result of the 3-martini lunch. It's not a pretty picture. This is a person with cirrhosis. I wish I had permission to show you the real pictures of a young lady who had cirrhosis. And there was only a 9-year difference between the first picture and the second picture. The first picture, she was 29 years old, and she probably could have passed for 16. She was just as pretty as a picture. 9 years later, she's 37 years old, and she probably could have passed for 70. That is how old she looked in the 9 years. Cirrhosis is not a pretty picture at all. Your liver fails. You turn a gorgeous, gorgeous color, shade of orange, just like that shirt. Right behind you, your shirt. Hey, hold it up. Yeah, that nice color. Your liver cells necrose, and they're destroyed. And they're replaced essentially by scar tissue. Okay. There's several types of cirrhosis. There's lanic cirrhosis, which is alcohol. There's post-necrotic. There's biliary. There's cardiac cirrhosis. Well, you don't need to know what each one, you need to know that there are different kinds of cirrhosis, but essentially the signs and symptoms are the same for all 4. Isn't that nice? Did I make your life a little bit easier? Okay. Early signs and symptoms include fatigue, anorexia, dyspepsia. Well, dyspepsia is what? Like indigestion. Have you ever smelt the burp of a person who's had early onset cirrhosis? It's a sourish, almost diabetic ketoacidosis kind of a smell. Yeah, that's how it smells. Lots of flatus. And that even the flatus smells the same way as the burp. That soury kind of a smell. Lots of nausea and vomiting and diarrhea, or they may be constipated on the other hand. Okay? A dull abdominal ache. And so because they got the ache, guess what they do? Drink some more. Because they say that the alcohol kills the pain. So this is my lady who's in complete denial. But I don't have cirrhosis. Complete denial. Fatigue and mental changes occur. Asterixis, which is the liver flap. And what's that? If you tell them to hold their hands out, arms out, their hands will actually flap like this. That's the asterixis. The other thing also is if you tell them to do the hands up thing. Stick them up, right? Put your hands up like this. Like when you play cowboys and Indians and you go, stick them up. And they put their hands up like in the stop position, the hands will flap also. Okay, so that's asterixis. And so her hands are flapping, but she's in total denial. Hepatomegaly can occur and ascites can occur. And what happens if there is ascites? What is your nursing responsibility? Measure the abdomen, right? And so when you measure the abdomen, you do what? You draw on the stomach with your magic marker. Jaundice, that gorgeous color. Spider angiomas. And you know what spider angiomas are? Those ruptured capillaries. And if you look, some people have them on the face, some people have them on the chest, where you can actually look, you can see the center is red, it's a red spot, and then the ruptured capillaries emanate out from it, so it looks like a spider. So these little spider angiomas can be all over the face or can be over the chest. And sometimes it's all over it can be in other parts of the body as well. You definitely have coagulation problems. So these people now suddenly start They start with what? Rectal bleeding.